Welcome to this April Collective for Align Maternal and Newborn Health. So delighted that you could join us today. And in this exciting opening session entitled Maternal and Newborn Health Action, what data, where and how, we're going to be meeting many people from around the world to share with us how we can together speed up for maternal and newborn health. We're halfway through the Sustainable Development Goal era. Data are critical now more than ever, or we're driving blind as we try to go faster. My name is Professor Joy Lawn, and I'm really honoured to be your moderator and your tour guide for this rapid fire, exciting session. First, some tips for you so that you can get the most out of this time. Firstly, bienvenue. Si vous parlez français, we have simultaneous translation from English to French. You can click below to make this available for you. Secondly, whatever language you speak, please join in. One of the sad things about being on Zoom is we can't be face to face, but one of the great things is it's an equal platform. We want to hear from you. Please post in the chat, put your questions in, and we will be having a very dynamic question and answer session later. The most burning questions will be picked, so please put your questions there. Thirdly, join us on social media. We can amplify this conversation. We can bring data to action. Do tweet and do use other platforms, and the hashtags will be shown on the slides and also below. And fourthly, use your vote. We're going to have a number of quizzes. They're not tests or exams. We want to hear questions and answers from you. So please join in, use your democratic vote. So today, we have more than 1,000 registered from all over the world. And our first quiz question is, where are you now? Which country are you joining from? So please look at the link below and answer. And we're so excited that we have people from every region of the world. That probably means also most time zones. So if you're very early or very late, special thanks to you for joining us. Please post, and then later on we will show a map of where everybody is coming from so that we can understand the dispersion, and maternal and newborn health matters in every country. We hope we will have people from all countries. And so let's move forward into our session. This April, I was shocked to realize this weekend that this is halfway through the Sustainable Development Goal era. We've got 7.5 years behind us and 7.5 years ahead. And yet, every year, we still have 5 million deaths for our community. More than 2 million stillbirths, more than 2.4 million neonatal deaths, and around 300,000 maternal deaths. This is shocking, and yet it's no longer on the global agenda. This is a moment for us to regroup and to say, how do we go faster in the next 7.5 years to stop these unacceptable deaths? Most of them are preventable. Most of them happen to the poorest families. And that includes in high-income countries where we have terrible inequalities for maternal mortality, stillbirths, and newborn deaths. So to do that, we need 3 things. First of all, we need to know where we're going. What is our destination? What are our targets? Do we know our targets? Halfway through, are we familiar with them? Secondly, we need to know our status. Where are we now? And thirdly, we need to know how to use those data to drive change. So thinking about our targets, we have 2 groups of targets: mortality targets for maternal, long-standing targets, newborn, new, and stillbirth, stillborn on the global agenda. We will be asking ourselves, do we know these? And this session will help us to answer all these three questions. What are our targets? What's our status? And what do we need to do to change that? As well as mortality targets, we have coverage targets, and delighted to say they're truly aligned for maternal and newborn health. So the Every Newborn Group and the Ending Preventable Maternal Mortality Group work together to align targets for antenatal care, skilled birth attendants, postnatal care, and obstetric and small and sick newborn care. So we've now got a quiz. We would like to hear from each of us. Do we know our targets? We're going to start with the stillbirth one. So the stillbirth target, and this question will come up. Please post your answers. We want to ask for that stillbirth target, which is part of the Every Newborn Action Plan, because countries and families asked for it. Countries and families also asked for it to be a sustainable development goal, but that did not happen, unfortunately. So is it a national or a global target? Which national target is it? You've got three options here, and we're asking all of you to cast your vote. Do you know what the stillbirth target is? I'm happy to tell you that 30 countries have targets set for stillbirth, specific targets by 2030, but it should be more than that. We have at least 90 high burden countries, 195 UN member states. So what is the target? The first answer here is not correct, even though it is a national target. The correct answer is B, that every country should have a national target of less than or equal to 12 per 1,000 total births. And if you've already met that target, then to close inequality gaps. If we move to the next question. So this is about the neonatal target. And this is the first time in history that we've had a global target for newborn deaths, despite the large number. So this target is part of the Sustainable Development Goal targets. Is it national or is it global? Do we know what it is? And very importantly, because it's a Sustainable Development Goal target, more countries have set national targets. There are in fact 78 countries now with a national target for neonatal mortality rate reduction. The answer B here actually is the child mortality target. Answer C is not correct, it's not a global average, and answer A is the correct average. And importantly, countries may pick to set a different target. For example, India has a single-digit target, very ambitious target to reach 9 neonatal deaths per 1,000 births by the year 2030. And then if we move to maternal mortality, this important ongoing tragedy of maternal deaths that are preventable has had a long-standing target during the Sustainable Development Goal era, and now during the Millennium Development Goal era, and now in the Sustainable Development Goals. In fact, it's the first target in the third SDG on health. 3.1 is for maternal deaths. So do you know what it is? Is it global or is it national? The first option, A, here says that it's a global average maternal mortality rate, less than or equal to 70 ratio, less than or equal to 70 per 1,000 live births. So all of these targets are the maternal mortality ratio. The second, B, and the third, C, are dependent on different baseline thresholds of your maternal mortality ratio. So for all of these, in fact, all are correct. The top one is the primary target, and all of these other two refer to your baseline and then a target that is important to meet. And our joint vision here is that no country would have a maternal mortality ratio more than 140 per 100,000 live births. So what we can see is actually many of us didn't know our targets. And maybe some of us knew some, but not the others. We are here for Align MNH. And it's very important that we stand for all three of these targets, which link together. So as we move forward now into our opening talks, we have three very exciting presentations from world-leading experts to set the scene for our conversation. First, we start with these mortality trends, reiterating our targets so we know them, looking at the trends. And this is led by the fantastic Lucia Hug. She is a statistics specialist at UNICEF. She's been working on child mortality for many years, and she's also a leading expert on stillbirth analysis. Second, we move from deaths to the coverage targets. Due in 2025, that's so soon. Where are we? And for these coverage targets, what are the quality and equity gaps? To talk us through that, we have the wonderful Professor Barros, also known as Professor Equity. And he's based in Pelotas in Brazil. And he's been a lead in the Countdown to 2015 and Countdown to 2030 Equity Analysis Group. And then third, we have a conversation with data based on COVID pandemic from the wonderful Dr. Sheikh Faye. He is a leading scientist in the Africa Population Health and Research Center in Kenya, and the Countdown lead across Africa for these analyses looking at the impact of COVID and resilience. Over to our three fantastic lead opening speakers.
Hi, I'm Lucia Hag. I work at UNICEF on the child mortality and stillbirth indicators, and I'm going to talk about the mortality trends to 2030. And currently, we face still enormous loss of mothers and babies globally. Nearly 300,000 maternal deaths occur every year, together with 2 million stillbirths and 2.4 million neonatal deaths. And these are not just numbers, but lives lost and families who face this tragedy every day. And in order to monitor the progress in reducing maternal neonatal mortality and stillbirths, the Sustainable Development Goals set the target for the maternal mortality at less than 70 maternal deaths per 100,000 live births globally. In addition, we have for the neonatal mortality rate the target of 12 deaths per 1,000 live births at the country level, and the Every Newborn Action Plan sets a target by 2030 for the stillbirth rate also of less than 12 deaths per 1,000 total births. And the global maternal mortality target is complemented by the Ending Preventable Maternal Mortality, which divides the countries into groups depending on their level and trends in the past to reduce the global maternal mortality. And if we look at the maternal mortality ratio based on the latest estimates, we can see that there's huge inequality in the maternal mortality risk, and that the regions in sub-Saharan Africa and South Asia their mothers face the highest risk and burden. And you can see that in the countries in yellow and red. These are really the countries where the risk is very high for mothers. And even though the maternal mortality has declined over the past, currently we are at 211 maternal deaths per 100,000 live births, much higher than the global target of 70 maternal deaths or less per 100,000 live births. And in terms of the stillbirth target, over the next decade, 20 million babies are projected to be stillborn if the current trends continue. And 56 countries are at risk to miss the INEP target of 12 or fewer stillbirths per 1,000 total births, and half of them will not even meet the target by 2050. And these countries, again, are concentrated in sub-Saharan Africa and South Asia, as you can see the countries in red on the map. For the neonatal mortality target, these are the latest estimates that were launched last year. For between now and 2030, we expect 23 million babies to be dying in the first month of life if we don't accelerate progress. And 61 countries are at risk to miss the SDG target. And more than half, 37 countries, will not meet that target by mid of the century. So really, immediate action is necessary. We must do better and move faster. We need to focus on a healthy start of life and improve the quality and equity of care in the antenatal period, in the care at birth, and the first weeks of life. And although we have made substantial progress in reducing maternal, stillbirth, and newborn mortality, still too many mothers and babies die from mostly preventable causes. And acceleration is urgently needed to achieve the SDG INEP targets and to save the lives of mothers and babies. And also we need better data to monitor the impact of COVID-19 on the mortality of mothers and babies, because we don't have the data system in place to really act to the potential impacts in the pandemic that occurred and will still occur. So the UN, IGMI, and other agencies, the WHO and UNICEF, we have these reports that present the latest estimates and also the website. We will be launching new maternal mortality estimates, also including the causes later in the fall, and also new stillbirth estimates, including the timing of stillbirths, whether it occurs during delivery or before, and also new neonatal mortality rates will be launched later this year up to the year 2021. Thank you.
Hello, everyone. I am Aloysio Barros from the International Center for Equity in Health in Pelotas, Brazil. And I'll be talking about progress in maternal and neonatal health. And the question is, are we doing enough? INAP and EPMM have 3 joint targets to assess maternal and newborn health. And these are 4 or more antenatal care visits, births attended by a skilled health provider, and postnatal care within 2 days of birth. And I will use in my presentation a combined indicator of these 3 that is basically a count of how many interventions were received by the pairs of mothers and their babies. We have data for 95 countries. These are all National Health Service carried out between 2010 and 2019, either DHS or mixed service. And note that all of them were carried out before the start of the COVID-19 pandemic. For the individual indicators, ANC 4 or more visits, we had 38% of the countries with a coverage of 80% or more. For institutional delivery, we had 61% of the countries with a coverage of 80% or more. And for postnatal care for the woman or the baby, we had 77% of the countries with a coverage of 60% or more, using the cutoff points proposed by INAP and EPMM. In terms of our combined indicator, we saw that in these 95 countries, 60% of all women and baby pairs received all 3 interventions. Then, looking at the countries, we found that 27 countries out of the 95 presented a coverage of 80% or more of the mothers and babies receiving all 3 interventions. The countries are listed there. I'm not going to read them all. And on the other extreme, we had 15 countries where 20% or more of the mothers and babies received no intervention at all of these 3. Is progress in terms of coverage being made for the 3 interventions at the same time? The answer is yes. We had data for 41 countries. These countries had 2 or more surveys with at least 5 years intervals that we could estimate the change. And 33 countries out of these 41 increased coverage. And the highlight goes to Rwanda and Zimbabwe, which increased coverage by more than 30 percentage points. We also see that larger increases were seen in countries where the baseline coverage was lower. 8 countries decreased coverage, mostly very small reductions, and the exception was São Tomé and Príncipe, that had a large reduction in ANC4+. Despite this progress observed in coverage, there is huge inequalities between the poorest and the richest. Among the 10% poorest mothers and babies, we had 44% of them receiving all three interventions, compared to 84% among the richest mothers and babies. That is, we have 40 percentage points in difference between the poorest and the richest mothers and babies, which is a huge gap. In conclusion, we can say that in terms of individual coverage, these three interventions have relatively high coverage, ANC4+ trailing behind. In terms of combined coverage, only 27 of 95 countries had an 80% or more of the babies and women and babies receiving the three interventions, while 15 of the countries had 20% or more of the mothers and babies with no intervention received. We saw that progress in coverage has been made, but there is a long way to achieve universal coverage for most of the countries. And finally, in terms of equity, we found huge gaps between the poorest and richest. Less than half the poorest women and babies are receiving all three essential MNH interventions. That's it for me, and thank you very much for giving me the opportunity to participate. Bye-bye.
So I'm going to talk about the COVID pandemic and the resilience of the MNH sector in developing countries in the world. And in my presentation, I'll talk about findings from two research that were conducted recently in 2020, end of 2021 and a bit of 2020. So my name is Cheikh Mbacké Faye. I'm a researcher, head of the West Africa Research organization for APRC, which is based in Senegal, Dakar. I just want to highlight these results that were part of the countdown, which is a multi-country, multi-academic initiative, which look at monitoring MNH performance in the world. So here, what we did was to focus on 10 MNH indicators, looking at institutional deliveries, ANC, outpatient, and some other indicators, but from 12 African countries. And we looked at the data from 2017 and then end of 2020 to see how the services have evolved during that time. And when you see this slide, you see that in the first months of the pandemic, there were these really seeming impact, effect of the pandemic on the services, where you could see the greatest impact. And towards after few months, you could see a bit of drop. A bit of the service going back to normal with almost no effect actually, and then that was really a response, maybe an effect of the governance response that were noted in many of those countries. And then we could also mention that the COVID pandemic, the COVID incidence and mortality rate were often larger in subsequent wave, but you see the disruptive impact on non-COVID health services were more limited. So this is a real finding that we've seen. And if you look at the next slide, where you could see now all the other services, actually, you see vaccination, inpatient, outpatient, and C-section. They are all similar, almost the same thing. What we've looked at in this slide is we also included trying to look at the major stringency index for COVID restriction and major changes, the percentage in service utilization. So here you could see that where you could see the drop or maybe the effect of the service of the pandemic, and you could look at that with regard to the major stringency index, which is the COVID restriction measures that were taken by government, and the trend is the same. No matter which service, you could see that it's exactly the same thing, a bit of impact in the early years, in the early months, and then coming back to normal. And also, we could see that there were some differences between urban and rural districts. I mean, where the services were provided, you could see that there were some differences. In the rural area, you could see it looked like there were less, I mean, a bit more limited impact rather as compared to that's the urban as compared to the rural, where you could see a lot more impact, which is the blue part of this side. And then, if you look at the WHO Pulse survey that were done in the last quarter of 2021, we've seen that 92% of the countries reported at some extent of this disruption, which is really something that aligned with also some other research that we've seen, that we've looked at. And the detail are in the other slide, where in the other graph, where you could see the specific for some countries, but I don't want to come into the detail. And is that there were more resilience in sub-Saharan Africa in general. Most sub-Saharan countries were kind of very resilient to COVID, trying to really not see a lot of impact, and that was really something that many studies have confirmed. And just to confirm and to conclude by saying that the pandemic impact on elementary services may be limited, yes, but large enough to derail progress towards SDGs. And that was really something that really we need to look at as program actors. And it will take major effect for countries and the global health community to rapidly overcome this adverse effect of the pandemic on the progress towards SDGs. And finally, just to say, there are some point I want to emphasize. Routine health information data offered a unique opportunity really for us to estimate the size of COVID disruption in general in Israel. But just 4 points. It's important to protect the services from the pandemic by, number one, improving data collection and use of data, leveraging the large investment for COVID-19, strengthening routing data for continue tracking progress, and then highlighting the major rebound and resilience of the health system in general. And those are really great points that came out from these studies, and we want to maybe stop it there. And thank you so much for listening to this presentation. Over.
Thank you. Merci beaucoup for all three speakers. They have clearly shown us gaps in our mortality targets, gaps in coverage, quality, and also equity, and additional hits during the pandemic for our services. But they all highlighted that we do have data. We have data to help us to do better, to close these gaps, but also how can we improve and use our data for action? So this is an important question to all of us. We have a quick quiz question now. In your country, for these coverage targets, so if we see the question, coverage targets on antenatal care, coverage targets on skilled birth attendance, and on postnatal care, are you able to track them now through routine data? So please answer, thinking about the country that you're in. And excitingly, if you also look at the map at the same time, you see we have people from countries all over the world. So in your country, which of these can be tracked through routine data? And what we can see for antenatal care, for births attended by skilled personnel, and by postnatal care, that there are countries in every region where people are saying you can track these through routine data. In the past, most of our tracking in high burden countries has been through household surveys done every 5 years. These are very important. But what COVID shows us is when people want to, they can measure things quickly and in routine systems and shift to electronic data. How can we do that for women and children's health? How can we improve and act on our data? So for each of these, any country should be able to track at least part of this through your routine data system. But all countries maybe have gaps in how well we can do that and in the quality of our data. And that leads us into a fantastic panel. So this panel is 6 wonderful experts from all around the world. And they're talking about how we can get the right data, use and improve it. Each of them has one question. Each of them could have had a keynote address. But those questions, I want to tell you, participants, came from your crowdsourced questions, things that you asked to be asked. So please join this panel and post your questions in the chat, because at the end of this, we will have a dynamic live Q&A with your most burning questions. Over to the panel. Welcome to this panel around the world and across all disciplines. And we're going to start with the wonderful Dr. Sheila Nchungwe from Mozambique. Sheila is a physician and also a very important lead in the National Mortality Data Collection Platform across the whole of Mozambique. Now, Sheila, we've been hearing about the urgency of mortality targets for the Sustainable Development Goals, now halfway through. Still too many maternal newborn deaths and stillbirths. What can we learn from you in Mozambique on your national platform for counting deaths, but also looking at cause of death?
So thank you, Joy. So I would like to start saying that in Mozambique, according census to 2017, data of mortality maternal rates was estimated 451 deaths per 100,000 live births, and the neonatal mortality rate at 28 deaths per 1,000 live births. As in most other African countries, most maternal and newborn deaths occur with the community and therefore escape the routine health information system that is exclusively facility-based. Data are specifically not available for maternal mortality, which also not well measured in household surveys. In Mozambique, we have established with the funding from the Bill and Melinda Gates and technical assistance from Johns Hopkins University, a national sample registration to routinely collect data and pregnancy births deaths at community level. The platform referred to as COMSA was established since 2007 in 700 clusters in all 11 provinces to produce data and national in each province. We trained verbal and social autopsy data collection that follow up all deaths to collect information necessary to determine the cause of death. Today, based on data collected, we know that 1/3 of neonatal deaths and 2/3 of stillbirths occur in health facilities, and about 45% of maternal deaths occur in health facilities. We are able to analyze the cause of these deaths and triangulate with other sources of data to interpret them appropriately for decision making. In short, I want to end by raising 4 key action points to ensure data availability and use in low-income countries. First, timely source provides short-term data, economically sustainable, but long-term system generates strong, reliable data. Second, the global community must recognize the value of a strong data system and provide investment to ensure maintenance of high-quality data. Third, we must take advantage of the digital revolution that we witness to build reliable data system. Today, mobile phones have penetrated all villages and communities in all countries. Finally, we must promote data awareness and efficient use. It is critical to ensure interoperability in data systems to also avoid duplication. All systems should ideally link to function national vital statistics system and generate continuous data and strengthens each other. Thank you. That's what I think that I could share with everyone.
Obrigado. That was just so deep and so perfectly on time. really the breadth and ambition of what's been done in Mozambique, and particularly that its government and system are being used for action is just so wonderful. I'm sure that there will be questions in the chat to you and to your team in Mozambique. So we're now going to move from Mozambique to your neighbor, Zambia. And in Zambia, we have the wonderful Dr. Chilwe Jacobs. And Chilwe has worked as a public health epidemiologist, particularly with a focus on equity and a gender lens. She's the lead for the Countdown to 2030 in Zambia. And Chilwe, one very important theme all the way through the SDGs is equity. Leave no one behind. But we can't know that unless we have the data and we use that data, and so many different groups that could be left behind. Can you talk to us from Zambia about equity, use of data, and closing those gaps? Thank you.
Thank you, Joy. It's a pleasure to talk about it. Let me start by telling you about this Countdown collaboration. So you've rightly put it that we have the Countdown collaboration team here in Zambia, and this team consists of the University of Zambia, Ministry of Health, University of Manitoba, and the Federal University of Pelotas. So in this collaboration, we've been conducting analysis of available data, as well as try to build capacity within us. Specifically, we have used data from the survey data, and this is the Zambia Demographic Survey data of 2001, 2007, up until the latest one for equity analysis. So in these analyses, we've estimated ratios, coverages, and associated confidence intervals for maternal and newborn health indicators, including child health indicators. We have assessed how indicators are distributed over time by looking at equity strata such as education, wealth quintile, and place of residence to assess how the level of equity in the outcomes have changed over time. And all this has been done in an effort to support the Ministry of Health, who are part of this collaboration, in trying to, in their decision-making processes. So let me go further to talk about this equity analysis and what we found. From this equity analysis, I want to give one example on what we have found. We saw that equity in maternal and newborn health services has improved strongly, actually, over the past 2 decades for most of the strata, such as a place of residence, including the provinces, the regions. But how did we know all these improvements and the gaps that are closing? I must say that this has been so because we have tried by all means to use the data that we have. It has been possible because also Zambia has a solid system of national surveys. We've been able to use 5 DHS data sets to try and tell where inequalities are existing and where the gaps are closing. So this tells us about inequalities related to wealth, urban, rural differentials, including education. But also, these surveys have allowed us to dig deeper, to looking into inequalities, especially within the provinces, within the places of residence, where we're able to see within the urban population which groups are being left behind. We then started looking into what has worked, because when you see the answers, you want to understand what has worked and for whom and why this has been so. And so this drove us into looking at policies and strategies that may have contributed to these improvements. But also, let me end by telling you the lessons that we've learned out of this. From this, we have noted that we have the HMIS routinely collected data that are never clean. And so to make them useful, there's need for a lot of work on data quality assessments, there's need for adjustments. And so we found that this is possible and we can use this data that in most cases is unusable. For instance, we have been able to use routinely collected data to assess the impact of COVID-19 on continuation of maternal and newborn health services. So this is what I have to say. And just a take-home message, what I would say is that let's use all data sources in creative ways and build capacity within the local teams, but also we act on this data, especially to answer local problems using locally available data sources. Thank you.
Joy, thank you. This is so important. We talk about equity, we analyze it, but most importantly, to actually use it. And so encouraging to hear, for example, the care at birth, which has had the largest equity gap in most countries, is being closed in Zambia, and that you're moving forward to use routine data, because that's one of the challenges. So thank you. I know that there are many crowdsourced questions on this, and I'm sure there'll be questions in the chat on especially the use of routine data for our equity analysis. So we're now leaping from the continent of Africa over to the continent of Asia, and we're zooming in on Pakistan. And in Pakistan, we have probably the most qualified woman to possibly talk on this topic, Dr. Sabeen Afzal. And she has been for 19 years in the Federal Ministry of Health in Pakistan. And she's currently the deputy and also the lead for information systems, and has led the National Digitization of Health Data initiatives. So, Sabeen, I would really love to learn from you, and I know from the crowdsourced questions that many others would love to learn. How can we use routine data to help us track and improve the quality of essential services for women and their babies? Over to you.
Thank you, Joy. A very good evening from Pakistan, and thank you for giving me this opportunity. Pakistan, as you know, is a devolved country, and as a federal ministry, our main role is of coordination and providing technical support to the provinces. The main source of essential or routine data is from the District Health Information System, which is paper-based at the periphery level, but as we go up, it is being digitalized and it's collated and analyzed at the federal or national level. Despite many challenges of the routine data of having a paper-based, not digitalized, sometimes not real-time, capacity issues, lack of infrastructure, IT infrastructure, it can be used for a number of initiatives. And Pakistan has used it for a number of health reforms in Pakistan. The most important being the development of Universal Health Package based on DCP-3, which is customized, and Pakistan is one of the countries to develop a essential health package, and for which the routine data has been used for developing, looking at the disease burden at the district level. Another important area where we use the essential health, for look at the essential health services, especially the RMNCA service, for during the COVID. Because during the first wave of COVID, there was a complete lockdown, and the data showed us that there was a decrease in the essential use of essential health services, especially the antenatal care services, the immunization, the institutional deliveries, etc. So this data was then used to make important policy decisions like zoning of the hospital, developing of the SOPs and guidelines during the COVID. So the essential health services are now being restored during the COVID and has been brought back to their initial level. COVID, while it has brought a lot of challenges to the healthcare system across the globe, it also had made health a very important, brought center of attention to the health sector. And what we have learned from the COVID is that we can harness the private sector, which has been giving data, which is not routinely it's giving data to the national database. But during the COVID, they were giving data so they can be harnessed and provided as an opportunity. Another Another opportunity that we see during using essential data is use of digital solutions for providing healthcare services during the lockdown. So this was another important area that can be worked using telemedicine in this. Pakistan accordingly has developed a digital health framework, national framework, which will be providing an innovative digital solution to the head district health managers so they can make evidence-based policy planning. And DHIS, as a way forward, we will be looking at DHIS to DHIS2 so that we can have introduce new variables and can also look at age and sex disaggregated data, because data regarding especially the adolescent health is still a gap that we have seen in the essential health data. So essential data all by linking it with other data stream, triangulating it can be used to make policy, evidence-based policy decisions and planning. Thank you very much. I'll stop here.
Oh, thank you. This was so deep. And what I see is we have lots of gaps that we're trying to bridge. So you talked about interoperability of your data systems, but we also have linking the national, federal level to province, linking your paper system to electronic, and then also this whole issue of COVID being an opportunity and a threat. So thank you for this. We have so much to learn. Thank you. So now we leap from Asia back to Africa, and we're zooming in on West Africa, where we will land in Accra, Ghana, with Madame Fopa, Dr. Sodsi Teti. And wonderful to have you here. You have really led so much of quality improvement in Ghana, but now acting as the lead for IHI across Africa and across Asia. And often we talk about quality of care almost as if it's a religion. But for it to work, we need the cornerstone of data. Data to drive what do we act on, and data to see if our action is working. From your rich experience, Sodsi, can you help us on how to use data for action in quality improvement?
Thank you so much, Joy, for your generous introduction. It's very impressive to know that you haven't forgotten your chi from your days in Ghana, in Kumasi to be specific. So you have put your finger on it about the critical role of data in driving improvement. And the first thing that I'll talk about is that a lot of the times people of the larger context, the larger environment, whether we have an enabling environment that promotes the use of data. And in Ghana, as in many other countries, you would see that increasingly we are relying on a national quality policy and strategy document and action plan that creates that sort of enabling environment. And within that document, we pay attention not just to the plan, but also to all dimensions of quality in terms of assurance, quality assurance, where we would look at whether the facility is at the primary level, secondary level, or tertiary level, and whether they have the requisite tools in place to be able to deliver basic or advanced obstetric service. So that environment is very critical, because if you do not have that enabling environment, you would end up with people concealing the data which reflects the true state of the outcomes and the processes that affect mothers and newborns. The second thing that I would mention is that everywhere you would see that there are a lot of, we have HMIS, which is the routine data system, and it is critical when we rely on those indicators to track the improvement initiatives that we're embarking upon to improve maternal and child health. What is often missing is that you do not have a subset of all of these indicators that reflect the core priority areas. So in many instances, you find that people tend to be overwhelmed. So whilst the HMIS is good, I think what is critical is that we have a core set of quality indicators that would then guide our efforts. And you know that in QI, we focus on the processes that lead to those outcomes. So it's important that when we have worked with a lot of rapid cycles of improvement, and we know which processes are most important, make efforts to include it in the routine data system if they are not already being routinely collected. The third point has to do with the fact that, yes, we have large national goals and we have many struggling districts and provinces and facilities. But there are also bright lights. So we want to move away from islands where we have no idea what is going on, but to be able to carefully identify the high performers and to do a good job of learning from their data on what is working and share those lessons with the parts of the health system that may be struggling. This way, we are able not just to focus on islands of excellence, but to spread best practices across the entirety of the health system. And that's the third point that I would make. The fourth point is that we already have in our health systems ways in which various people at various levels interact. So whether it's clinical meetings, whether it's review meetings, to make sure that we focus on the data to know what people are specifically doing to improve the quality of healthcare. The next point I would make has to do with the quality of the data itself. In many places, you'll find that there's some amount of overconfidence in the quality of the data that is done. And the work that we've done shows that you cannot guarantee that what is being collected at the facility is the same as what has been reported in the routine data systems. So really press on with efforts to remove the completeness, the accuracy, and the timeliness of the data collected. And this is work that we've done to improve the quality by matching what is collected at the facility level with what is reported at the district, national levels. And the final point has to do with making sure that we are increasingly bringing the voice of the patient into the conversation and recognizing whether from the patient's perspective, the quality of care is being addressed. And in Ghana, you may be aware of the work done with a community scorecard to harness the views of the patients and to infuse it within the data systems and to track how the communities are perceiving the quality of care. Thanks a lot, Joy.
Thank you so much. So profound, and I wish we had more time. I can see so much to learn from you. That quality of care is also the experience and the ownership of the communities. That we need quality of care, but we also need quality of data. And we probably need less data, not more. Core indicators and use them well. So important. And these really reflect some of the crowdsourcing questions. We had more than 200 crowdsourcing questions, and quite a lot were on these topics, which indicators and how to use them. So now we come to India and to the giant and amazing state of Uttar Pradesh. And there we meet the director of the technical support unit in the ministry. This unit has done a remarkable job in analysing and applying data for action throughout this state, seeing transformation over time. And so that data platform was ready when COVID hit to be able to inform policies to protect mothers, newborns, and stillbirths. Here, I would like to ask you, Dr. Vasantha Kumar, as somebody who has been able to use data for action during this pandemic, what have you learned? What have you been able to do? And how can we learn from that for other places?
Thank you very much. Uttar Pradesh is the most populous state of India, with 1/6 of India's population, 235 million people, 75 districts, 800 blocks, which are sub-district units, and more than 25,000-30,000 facilities. Managing a COVID-like pandemic required a credible data system. The data system was established from 2017 by Uttar Pradesh Technical Support Unit for Government of Uttar Pradesh. It has more than 30,000 facilities reporting month on month continuous data on aggregate basis. Now, this particular data system allowed us to find out the negative impacts that happened in antenatal care, routine immunization, family planning, etc. The technical support unit works to improve RMNCH outcomes in Uttar Pradesh. Initially, when the first wave came, the community level platforms and facility level services were completely stopped as we were not knowing what to do with the pandemic. But after some time, the data system allowed what is the amount of negative effect, which was too deep. And so we started services, the community platform, in those geographies where the COVID was lesser compared to other districts. So the data system allowed us, with a gap of less than 1 to 2 months, to identify where the reduction in antenatal care, routine immunization, family planning, and other services are affected. During the second wave, Uttar Pradesh and India had 3 waves. First was the wild wave, and then the Delta wave, and then the Omicron wave. The lessons we learned in the first wave enabled us that even during a severe second wave, we did not stop any of these services. Rather, we took mitigative measures. And we were also able to regain the drop in institutional delivery or comprehensive emergency obstetric care management services and other things faster compared to the first wave. So these were the utility of the aggregate Uttar Pradesh Health Management Information System that was established by UPTSU. We always felt that aggregate data system has its own limitations. So using COVID pandemic as an opportunity, we established the first unitized data system which captures the life cycle of a COVID patient, right from testing, tracking, and treatment. So we are happy to inform that we have more than 100 million, which is 10 crore people, data of sample available in this unitized data system, along with contact tracing and those positive patients' hospital or home isolation outcome details. So this made us realize the power of unitized data and how we can take evidence-based policy decisions. The support that we give also enabled Uttar Pradesh government to undertake periodic statewide zero surveillance system, which also enabled us to track the progress of COVID pandemic. I'll stop there. Thank you.
Thank you for that really thoughtful and deep answer. So much to be learned from COVID, both as an opportunity and as a threat, and a great opportunity for us to improve and use our data systems for action now and in the future. I'm sure there will be many questions about your thoughtful comments in the chat. So moving from India to the beautiful country of Nepal, last on this amazingly rich panel, and definitely not least, my friend, Dr. Sudha Sharma. It's so beautiful to see you here, and I know that many of us have learned from Nepal, and particularly the use of data across district health platforms to improve and really change services and understanding that data, the kind of data literacy component. So Sudha, you have worked in Nepal, but also I last saw you in Tanzania when you were the chief of health for UNICEF. You have such a deep experience of this. What can we learn from Nepal, but also from your own experience on the use of data in practice? Thank you.
Thank you, Joy, and greetings, everyone. It's such a pleasure to be back here again. I think in Nepal's district health system, data use is always given priority. Our district health managers are mostly trained in data quality assessments and cleaning up and things like that. And also there's a system of periodic reviews. So we review our data every quarter and semi-annually and annually. And all of this at the district level and above, at the provincial level and at national level. The national annual review comprises of Nepali partners as well as development partners, and including academia, researchers, and NGOs. So it's a huge platform where everybody shares and talks about data. And also we try and triangulate whether what we are receiving is accurate. And like in other countries, we just heard, in Nepal also, we do disaggregated data because the country is so diverse. We have highest mountains, and then the mid hills and the plains. And the situation of health services is not the same across the country. So disaggregation and equity is given very high priority. And I'm very happy to say that we have actually done a lot to bridge the gap, and service utilization among the poorest quintile, among the most geographically marginalized communities are increasingly better. And also the government has made a roadmap to 2030, where priority attention and strategizing what kind of intervention will be suitable for which part of the country. So overall, I think some examples of data use in Nepal is around the system of maternal and perinatal death audits, and even our free care program, AMA program, was initially started as just the travel incentive, an incentive to health workers. But later, after thorough evaluation of our data, we actually managed to, work around making it free for everybody. Same with when abortion was rolled out nationally. All of this was based on data and evidence. And in terms of newborn care, we've done some amazing work with introduction of chlorhexidine and community-based newborn care. So all of those have contributed to reducing maternal and newborn mortality in Nepal. And overall, I think, as in other countries, even during COVID, we were able to review data and fill the gaps where we saw stark gaps. So things are improved. And I'm looking forward to actually meeting the targets because of this roadmap, which has been designed, based on evidence and data. So over. Thank you.
Zuta, thank you so much. As someone who is an obstetrician, but also I think a key architect in that roadmap, we learn so much from you. And I believe that, Nepal was one of the few countries that met both the maternal target and the child survival target, and is probably on track for the SDGs, but not for the poorest. So I know that that's in your mind. How do you use the data at district level? And I hear now municipal level to change that. It's very inspiring. So deepest thanks to this just amazing panel. Thank you. And we open for questions to everybody who is here today. Well, what a rich panel all around the world, and so much interaction in the chat. We're going to jump straight to your exciting questions. And one of the most burning issues is about improving routine data quality. Just noting that for tracking antenatal care, 95% of you said you could do this through routine systems. Skilled birth attendants, 90% said you could. And postnatal care, 83% said you could. So we believe we can, but everybody's questioning the quality. So I'm going to pass first to the wonderful Dr. Chorwei Jacobs. And I want to ask you, how could we actually reduce the burden on health workers and the data systems so that we could improve data quality? Over to you, Chorwei.
Thank you, Joy, and thank you for that question. Indeed, data collection can be burdensome. And so it would be very critical that even as we think about using this data, we need to think about integrated digital platforms so that we avoid segregation of small segments of data sources. So using integrated sources would be good, but also mentorship of the data collectors, people that collect data. We need to invest in training them, in providing them mentorship so that they're able to provide us with quality data. Because most times we see that the data, when we want to use it, we find that it's not usable, it's of poor quality. So starting from the base, from the foundation would be very critical. Thank you.
Thank you, Chorwei. So we need to look at the people who collect the data and their motivation and support them. I think that is really critical, and less is more. So, can we delete some things? So I'm going to pass from you to the wonderful Dr. Shabin, who has led the electronic data system transition in Pakistan. And we want to hear from you. This is a question that's come up in the crowdsourcing and in the chat. What ways, tips could you give to other countries for a transition to electronic routine data, particularly for maternal and newborn health?
Thank you, Joy. I think we could start with a smaller thing. Whatever the data is available, start collecting and digitalizing that available data first. And then start looking at cleaning the data and analyzing the data. And then you start looking at what the problems are arising or what the good things or strength of that data. And then build on the strength and improve the gaps. What we have done is that we've started with the smaller districts or one district or two districts. Pakistan has 154 districts, so it's a big populous country. So starting with a smaller district, look at see how they happen, and then gradually improve it and keep adding things to it. And that has had helped us a lot. But like my previous presenter said, we need to focus on building the culture of using the data and training and responding back. Sometimes they keep sending us reported, but the higher level should regularly respond back to them so that whatever, so they can improve on the efforts they have. Thank you.
This is brilliant, Shabin, and I think it builds on what Chulwe said, that it's also an interaction. People don't like to collect data and send it into a void and nothing comes back. So I want to pass to our colleague, Dr. Sodsi Tete in Ghana. We've been talking about the quality of the data, but we also want to use the data for quality. Do you have any tips on how people can really use data to drive quality for maternal and newborn health and stillbirths?
Well, a couple of points. We can use the data certainly to be able to map out the gaps. And there at the system level commission some improvement work. So quality improvement teams working through rapid cycles of tests. And I like the idea of starting with what you have. So planning some cycles, implementing, learning from what is working before one then decides to scale up. Another important idea will be to create some learning network of facilities that are working at the same level so that they can learn from each other what is working and what is not working. And this is not just with respect to midwives, clinicians, but also with data officers, that they have their own network where they can audit their work and give feedback to each other on the data quality gaps that often exist. Thank you.
That's fantastic. Start where you are, start small, use peer learning, but be ambitious. And I think a critical message of less is more. Have fewer indicators, measure them well, and use them. This is so critical. So we're low on time for questions, but we've had a lot of questions on COVID. So I'm going to pass to Dr. Visan Kumar and to ask you, COVID has been so ambitious for data, moved so quickly. What's one tip you can give to people to seize that opportunity from COVID to improve our data systems?
Thank you very much. The unitized data is what I think will be the next big step. So in Uttar Pradesh, we have 6 million pregnant women and an equal number of children who have to be kind of catered to every year. Today, we know aggregate data, geography, and the heterogeneity and the equity part of it, but we would like to gather the data in a unitized way, and COVID has given us that opportunity to learn and create such a system for our mother and children also. Thank you.
That's just beautiful. And you were so concise. I really appreciate that. And, for our other panel members, there was such richness. What I hear is that we need more time. So when we meet in Cape Town next year, I know that each of you have a vision for what can be different. So we're going to hear from all of you now. What will be different in the next year? What's our ambition for improving and using data for the maternal and newborn health community? So to close this amazing panel, we want to set out a drumbeat for change for this time next year when we will hopefully all be in Cape Town. I'm going to ask each of these amazing panelists, what's the one thing that they would like to see changed in Data for Action by this time next year?
Yeah, thank you once again, Joy. So I think definitely my biggest focus will be on disseminating recent and accurate evidence related to maternal and neonat health to policymakers, civil society, sub-national level. I'm talking about provincial and district for Mozambique and the population at all levels.
The one thing I would want to see change, or one thing I would be happy to come and share, particular experiences, would be linking different maternal and neonatal mortality data, which is most times has small sample sizes, to try and track and examine inequalities around maternal and neonatal mortality.
Routine data recently captures only the public sector nowadays. So I would like to see it linkages developed with the private sector, with the tertiary care hospital, so that we have effective service coverage, monitoring available, data available for the district manager, so they can make evidence-based planning and then having a disaggregated data as well.
Well, I would look forward to a future where we bring the patient's voice deeper into the conversation. There's a lot that we have to say about quality of care, and we are sometimes overwhelmed by indicators. But if you look at what happens in the area of family planning, also in the area of HIV, there's a more cohesive set of core indicators. And I hope that we would have those and also reflecting the voice of the patient across the continuum of care. Thank you.
Learning from the COVID unitized data system, the absence of unitized data system, who are the women who are pregnant? We have 6 million pregnancies in Uttar Pradesh every year, but we don't have the line list of these pregnant women, the outcome of these pregnancies, the immunization status of these women, because our services are delivered at the community through a platform called as Village Health Nutrition Day. So from now onwards, within 1 year, we would like to have a comprehensive primary healthcare digital platform which captures the life cycle of women from pre-pregnancy to pregnancy to outcome and the children delivered at the primary healthcare system. Thank you.
For me, as I said before, our district systems are quite good, but going down to the community level and building the capacity of the municipal data managers would be one, and like Pakistan, bringing the private sector on board. Second priority. Yeah, over.
So important, the ability to use and improve data locally. Thank you all so much. And so at the end of this session, we want to just thank again each of the 3 speakers, each of the 6 panelists, and also all of you for joining. And our purpose today is to start a drumbeat, the road towards the meeting in 2023. And by then, we want to work together, all of us as a community, to have a measurement improvement roadmap for every newborn and for ending preventable maternal deaths. What can we set out to improve and use? Not just moaning about bad data, but improving it. Not adding lots of extra data, but being clear on the key things to measure and what does data quality look like. We invite you to join us on that journey so that by May next year, we can be much clearer on that measurement improvement roadmap. Join us tomorrow for a wonderful session on respectful care in 2 different regional groupings. And please visit the Align MNH website to find the resources that we haven't been able to share in detail here, including ways to measure and assess your indicators. For example, the EN mini tools that would help you to do this for maternal and newborn health. So please share your resources, use the resources, and keep this conversation going so that together we can use and improve our data and make more progress by 2025 and meet targets by 2030. Thank you, and thank you to all involved in the organisation of this session, from Align MNH and the organisers who put together this agenda, which was Dr. T. Spoorma and Dr. Alison Moran, also with Francesca Conway. Thank you all so much.